Well, greetings, friends. It's Danielle Smith, president of Alberta Enterprise Group. And I am very excited to introduce you to our next guest because when I walked into his office, it's a doctor's office, it's a naturopathic office, but it felt like walking into a spa. It was an entirely different experience than any medical office I'd walked into before. And we're going to find out a little more about what they do because they combine conventional medicine with some of the new treatments. And I'm quite interested to know if this is going to be the new wave in primary care as we go forward, especially in this COVID era, as people are looking for a number of different options. But the amazing thing was that we had this conversation. I was supposed to go for a tour, but we got so deeply into talking about medical research and how to analyze conflicting data on COVID and what do we do about those who have vaccine injury and long COVID, that I thought, you know what, I better have Corey Deacon on so that you can hear the amazing things that he and I talked about firsthand. I'm joined now by Corey Deacon, who is the medical director at something called Nirvana. It's perfectly named, and we're going to find out a little bit more about this growing area because it sounds like Nirvana is going to be potentially coming to a community near you. Corey, thank you so much for being with me today.
Thanks for having me, Danielle.
I'd love to know a little about your direction and how it is that you found yourself in this role, because you and I had just a great conversation about the two different paths that you can take, either into medical research or to become a medical doctor. And you had to make that choice to go into the research side of things. I'd just love to know a little bit more about the background that you've got.
Yeah, well, mine is a bit of a personal story. In my early 20s, when I was in university, actually when I was in my master's program, I started to develop issues mainly related to my brain and my mental health. Started getting pretty substantial subjective cognitive decline. Started getting anxiety, panic attacks, what a lot of people would call depression. I know now that wasn't really the case. It was actually a zone that my nervous system was shifting me into due to basically my resources being overwhelmed. And a lot of people actually, have flipped themselves into what's called the dorsal vagal state or the faint freeze state. Of course, I went the first direction that everybody goes. You go see your family doctor and you go, hey, this all of a sudden started happening to me. I don't know what's going on, right? And it was interesting because as a researcher and someone who never really needed a lot of medical assistance, it wasn't about figuring out what was going on. It was just about, well, try this drug. Let's see if that makes you feel better, And that was really my only options. And I was more wanting to know, okay, why is this happening to me? What's going on? I wasn't interested in, well, you have general anxiety. Well, I never had problems with that. Why is it happening now, right? And there was a lot of assumptions that were made. Nobody ever looked at my brain. Whether an MRI probably wouldn't have been helpful or anything, but nobody did a functional assessment of my brain. And I found myself in this limbo where I was like, okay, I could try some medications. They didn't work, by the way. Or I started, of course, looking into the research because that's what I was trained to do. And I found myself kind of on the natural side and looking at some of the natural options. And I'm not against pharmaceutical meds by any means, but I really wanted to get answers like, what the heck is happening here? And then when I did find myself on the natural side, I found it was very similar in a lot of ways, where it was like, oh, okay, you have anxiety. Well, here's this herb, here's this amino acid, here's this vitamin. And it was like, okay, still not getting answers, still not understanding underlying cause. And then I was introduced, of course, in research in the neuroscience program I was in, to functional MRI and a technique called quantitative EEG, which is a way that we can take the EEG or the electrical activity coming off of the brain, map it out, and really get a sense of what is going on in the brain. And from there, we can actually dig into further labs, further tests that actually allow us to see with a little bit more specification what's actually going on, what's driving things. Alberta Health testing is really there to find severe cases. So most people, and my case included, I didn't show up on any of the blood work. Everything looked fine, until I started looking at some more more specialized markers, some more sensitive markers that actually showed me, oh, okay, here's what's going on with my immune system. Inflammation is really playing a factor. It's just that I'm not showing up in the tests that are typically ran through Alberta Health. And so that took me down a huge rabbit hole into functional and integrative medicine, where we're utilizing tests and we're utilizing biomarkers, objective biomarkers that allow us to see how the body's functioning and what may not be functioning well. And so that, it's interesting. You talked about post-COVID in your introduction. It actually led me down the path of finding out that I actually had chronic inflammatory response syndrome due to many concussions that I had as a teenager, and actually a water damage building exposure that I had that I didn't actually know about. So all of again, these labs, when I actually ran them, I found something, and it was like, okay, now I have an actual diagnosis, and I don't just have a diagnosis based on symptoms. That's not really going to get me anywhere. And so and now we're here. This is, I'm 10 years now since I figured out what was going on, and I'm 7 years pretty much symptom free. And we've developed now this clinic that is a lot about not only, of course, clinical treatments, but about research as well.
Well, let me pause you, because you've put so much on the table. I want to address a couple of things, because I feel like the traditional medical practice is in conflict with some of the things that you were talking about, and the way you've described it. It shouldn't be in conflict. It should be complementary. It should be that you want to find root causes and resolve them if you can, so that you can avoid a pharmaceutical intervention. If you just simply start treating with the symptoms with pharmaceuticals, you may never resolve the underlying problem. So you could end up being on a course of treatment that could last years or even for life. So explain to me why we don't have more integrative medicine. Explain to me why it is that there does appear to be a conflict, because they're both very grounded in research. It's grounded in testing. It's just taking a different path once you are trying to search for the problem. So why don't they work together more frequently?
Yeah, well, I think the field of medicine has really gotten into this over standardization approach, where the goal is to try, of course, to have basically a recipe book of, here's our symptoms, here's our diagnosis, here's the treatment that should work. And the reality is everybody's biochemistry is so unique. Our epigenetic expression is incredibly unique. So we really need to take the individual in front of us, try to forget everything else, every other patient that's come through our office in the last, day or the last weeks, and really look at the individual that's in front of us and look at, okay, what are the multiple factors that might be going on for this person? So, it's not that we ignore the diagnosis of anxiety or depression or bipolar, but we really look at, okay, why, what is manifesting in the brain that is driving these symptoms, and what is putting a load on the nervous system. It's incredibly time consuming. And it's an expensive process. It's not, you can't run basic $5, $10 lab markers to get your answer a lot of the time. So I think a lot of it comes back, in public medicine. I have a ton of colleagues in the United States, and they have a different way of doing things down there, where, they're more about looking, they run a lot through insurance in terms of lab coverage, where up here, we don't really have that option. We have a chunk of money that the government gives to Alberta Health Services, and they have to make sure that they have enough to be able to take care of the entire population. And unfortunately, they're not utilizing testing services and their financial resources that they have to actually look at this. Because again, we spend 2 to 4 hours with people just in the initial consult to figure out what's going on. And I think that time is limited and financial resources are limited is kind of the way I see it in Alberta.
It's such a good point because I think, and I've seen this before, is it's sort of a notion of don't go looking for trouble. We don't need to prescribe unnecessary tests. I know that my parents have had conversations with their doctor about that. But that's, I guess, the interesting part is that if you do more testing up front, then you can save money on the back end. And that's, I guess, how do you balance that? Because really, it's kind of limitless number of tests that can now be ordered. And I wonder if this is also maybe you hesitate to talk about it, but is this maybe a role for private medicine where people can pay more of that cost out of pocket so that they're able to get the diagnosis, or how much of it should be covered by public insurance? It's a bit of a balancing act.
It really is. And I think, sliding scale medicine may be something that we need to look at, where if I have the money to pay for part of my x-ray, part of my MRI, part of my lab work, or as you said, if I say, hey, money is not a problem here, I don't even care if I need to finance this. If I can take 10 to 20 grand out, I can get answers and I can actually get a predictable treatment program. I don't care. I just want to feel better. And that's where most of our patients are at, right? Is they just want to feel better. So, they're willing to do what they need to and pay what they need to get there. So it is a very interesting balancing act. And I don't have all the answers for that, but I know we need a different model.
Completely. Let's talk a little more about, because one of the things I know off air, I said, is there any question that I asked you when we met privately that you wouldn't want me to ask you publicly? And you said you didn't say I couldn't ask this. So I'm going to ask you it. But it does get to this issue of again, why there might be some conflict with traditional medicine. I remember we started our conversation by me just saying, I've been astonished by how incurious doctors seem to be about all of the medical research that is coming out around SARS-CoV-2 and potential therapeutic treatments. I mean, I regularly go to this website that one of the doctors, I have a couple of really good doctors who've been advising me all the way through COVID, so I can understand what the heck was going on. But there's a website called C19early.com. And there's over, I think now 1,200 different research studies on there where you've got doctors who are doing a whole variety of just different therapeutic treatments. And it shows the relative effectiveness of being able to keep people out of hospital and reduce inflammation and keep people from dying. And I thought, this should be standard. Why aren't people looking at this? It seems anytime you try to have a conversation about, is there something that can be prescribed to someone to reduce their likelihood of hospitalization, you'd think that would be the first question doctors would be wanting to know. And yet I've got all kinds of people who try to have that conversation with their doctors and they get shut down immediately, told, go home. You have trouble breathing or your lips turn blue, then go to the hospital, which seems to me to be counter to what I would expect out of good medical care. So I asked you a little bit about why it is that doctors seem to be incurious. And you had a really good answer for that. And I wonder if you want to walk through kind of what you observed at medical school that made you go the medical research route.
Yeah, well, yeah, I think from day one in medical school programs, you're really taught to follow a certain standard. You're not really taught to think outside the box unless an MD PhD program. They're incredible for helping you be really rewarding curiosity. So yeah, there's this idea you're overloaded with information. You need to know the prescriptions. You need to know the basically what I call the recipe book of medicine. You need to learn that inside and out, and there is no real critical thinking involved in how diagnoses are approached and then what treatments are utilized. And then when doctors get into the employment of, say, Alberta Health, curiosity is it's not only is it not rewarded, it's punished in a lot of ways where there's a management sector that's looking over these doctors going, no, you can't order that test. You better have really, really, really good reason to order that test. And they're just, curiosity is completely stifled. So the idea of individualized care kind of gets thrown out the window because, if somebody doesn't fit into a certain box, then, no, we're going to cancel these tests because there is no good reason to run them. And we found a lot of cases where tests are getting canceled through Alberta Health, and then we run them privately and we find issues. So it's, a lot of it is not necessarily that doctors aren't curious, it's that curiosity is punished. So it makes it really, really hard to move forward. And with any bureaucratic process, we know can be quite slow. And a lot of researchers show the data on this, that we're 20 to 30 years behind in public medicine at any given time. In some fields of medicine, we're even further behind, like psychiatry. So it's a big problem.
It is a big problem. And it makes sense though, now that you've described it that way, because I think anytime I've ever gone to my doctor, it's been a 6 to 7 minute visit. And you have to wonder how much can they really be able to delve deeply into what's going on with you if it's only a 6 to 7 minute visit. And so you've got to go to the, as you call it, the recipe book. So let's then talk about how different it is, your approach, because you can feel the difference immediately when you walk in the door, because immediately when you walk in the door, as I said in the opening, it feels like a spa. You've got beautiful colors and nice wall lighting on sconces, and it doesn't have that kind of astringent medical feel to it. So there must have been some thinking in behind even just your location and how you've structured your office. And why is it so different?
Yeah, there's a field of study called neuroaesthetics, and actually the environments that we surround ourselves by, or that we surround ourselves with every day, actually have an effect on our brain. So when we walk into a room, into a clinic that's tight spaces, small rooms, white everywhere, it's very box-like, it's not warm, it automatically actually triggers the sympathetic nervous system response. Our brain it evolved with nature, right? And so the closer we can have our patterns to nature, circular like rooms, open rooms, glass rooms, warm lighting, warm colors, it automatically triggers the parasympathetic nervous system response, which is what we need to get into that state in order to heal. If we stay stuck in this sympathetic nervous system response, it's very difficult, and I would actually argue impossible to fully heal. So it's kind of really interesting. The more you learn about the body, for one, the more you know about the body, the less you know, the less you realize you know. But also, it's a self-healing system. You just have to get things out of the way, and the system will heal. And I think medicine has really strayed off in the opposite direction, where it's almost like without intervention you won't heal. Without us giving you something, you won't heal, you won't get better. And really the opposite is true. That the body can heal itself. You just need to get whatever's preventing it from healing, whatever's preventing it from getting into that parasympathetic state. You get that stuff out of the way, and the body heals. It knows exactly how to recalibrate.
You are very much on a collision course there, I think, just with that, with the approach that we do take to medicine. And it's so interesting to me, because I've had this debate with some of my older friends, because I'm kind of a clean living person. If I need Advil, I'll take it. But generally speaking, I don't want to be on medications. It's just sort of a personal choice. But I kind of, whenever I have that conversation with those who are on multiple medications, they look at me like I have two heads. And I think that there's this argument that, well, the reason we've got a much greater longevity and a healthier population is because of all the medical interventions and because of all the pharmaceuticals. And in the natural world, we used to die very young. And so I think there's sort of a reluctance to accept that the body can heal itself. So give me your best pitch for that, about why it is that there is sound science behind the notion that just allowing for the body to heal without intervention could, in some cases, be the better option.
Yeah, well, and I think that both sides are true, because yes, there are medical interventions, no doubt, that have allowed us to live longer, healthier lives. The interesting thing, though, is if you look at quality of life studies, is yes, we're living longer, right? Great. We have things like metformin to manage insulin resistance issues, so people aren't dying of diabetes and complications from diabetes as early, for one example. But if you look at the quality of life studies, we're living longer, but we have more years of poor quality of life. So it used to be, I think it was in the 1950s and 60s, we had around a 70 to 72 year lifespan with about 6 years of unhealthy living. Now we have an 82-year lifespan with an average of 16 years of unhealthy living. So all that we've done, yeah, sure, we've prolonged life, but at what cost? Right. There's a lot of people I see that are in their 70s and some even in their 60s that are literally would prefer not even to live anymore because they're suffering so badly. And so to me, that's not really living. That's, sure, we're extending life, but if you don't have quality of life, it's not living. So that's my argument for that. If you look into the hygiene hypothesis, there's been a lot of just improvements in hygiene that have allowed us to extend our life. And the argument can be made that the intervention with, mass use of pharmaceuticals has, again, helped us prolong life, but our quality of life just is not there. So in the aspect of this type of medicine, we don't have enough research because this field has only really been around for 10 to 20 years. So it's going to be really interesting to see in another 40 or 50 where people are at. But I think the awareness that is now made around diet and nutrition, exercise, and a lot of people taking their health into their own hands, it's again going to be really interesting to see in 40, 50 years where we're at. I really don't see any reason why we absolutely need pharmaceutical intervention for everybody that is having problems in order to have that longevity. A lot of the patients that we see, 90% of them come off of their meds or substantially lower their medication dosage because their body doesn't need the same dosage to be able to manage or cover up the underlying problems that are going on. So in my case, again, not against pharmaceuticals whatsoever. I just think there are better ways to move forward and use pharmaceuticals as a tool, right? Because it's really one tool that's in a practitioner's toolbox. And so if you have a hammer, everything looks like a nail. But the reality is sometimes other tools are better used for the job. You don't want to be hammering a screw in. You'd prefer a drill or a screwdriver.
That's
right?
a great way of putting it. So I guess I wonder if this resonates with you, because one of the things that I've heard is that our current way of delivering healthcare is that we have a sickness system as opposed to a wellness system. That once you've gotten to a point where you're sick and you need to enter the system, then that's where treatment begins. But we spend very little time talking about the things you need to do to keep yourself well. So I just wanted to put that to you and see if that resonates with you.
Yeah, absolutely. That is really what it is in place for, because again, I think what we have for resources, both manpower as well as finances, we're not able to see everybody that's having mild to moderate ailments. Like we need a system that helps us intervene when there's something severe going on. But if you don't meet that severe criteria, like if you're within the range, so to speak, then you're okay. There, no intervention is going to be given because we just don't have the resources for it. So that's very much what it is. So a lot of people, they don't feel well, yet they don't meet any criteria to get great treatment, right? And so then we leverage insurance companies and pharmaceuticals because those are covered through insurance and they don't cost the province anything, right? So yeah, it's really interesting. And you look at a few cultures around the world through history have actually had an opposite system where you pay your doctor when you're well. And as soon as you are sick, you stop paying them. So it's in the doctor's best interest to keep you well. And I find it very, very interesting looking at systems like that. Japan has utilized systems like that in the past. And China, I believe, actually parts of China have as well. And so really kind of an opposite look at it, where, it really puts us in the pressure point where we need to keep this person well. So if somebody comes in and they're like, no, you know what, I'm feeling good, I'm doing this, so I think I'm good, right? It's really in your best interest to keep up and follow them and make sure that they're not engaging in behaviors that's going to set them back.
That makes so much sense. I'm going to have to take a closer look at how that kind of payment model would work,
Yeah.
because I wonder if you could get there from where we're at right now. Because where we're at right now, it really is on a pay per service type of model. And so you really are, there's not really much in the system to benefit anybody.
And it's rewarding institutions for people being sick, right? So underlying is this energetic that, well, if people are sick, we actually make more money, right? And it's backwards. It's backwards.
It should be the other way. You're totally right.
Yeah.
So then let's talk a little more about the kind of services that your clinic provides, because I was amazed to see that you do have oncologists on site and on staff to help those who are dealing with cancer. So you've got, and it's a combination of being able to deal with the wellness side as well as treat the disease. And so I thought, well, that surprises me. And so tell me what else people might be surprised about the kind of about the approach that you take when you're treating patients, because it's a lot broader than I expected.
Yeah, we have some collaborative partnerships. We can't do everything under our roof, obviously. We're not a big hospital or anything like that. But neurology, psychiatry integration, where and this is where the field I work mostly in is helping people understand their brain, what treatments can be used to stabilize them, because that's really important. And this is where pharmaceutical medicine is phenomenal, is bringing stability into people that are dealing with psychiatric or psychological problems, or neurological problems for that matter, until you can look deeper at what's going on and then utilize other therapies that, we know in the research can be complementary. And, in terms of the neuropsychology side, we do work with trauma. We do work with neurofeedback, where we help teach the brain how to regulate itself, rather than depend on, a medicine or a pharmaceutical or psychotropic medication that's very non-specific. We don't have a good predictability of exactly how it's going to work in the brain. Medications like this, what they'll do is they'll increase the likelihood of an area of the brain, whether an area of the brain is going to fire, or they'll decrease the likelihood of an area of the brain firing. But they don't have the ability to go in very specifically and say, and I might just maybe share my screen right now.
Let me put this up.
Yeah, this is just an example of what we look at with a quantitative EEG. So, in a brain.
So let me pause you, because I do post this as a podcast as well, so people might not see the image. So just describe what you're showing us here.
So what we're seeing is a functional analysis of a brain, and we're looking at frequency expression. So basically, how loud a certain frequency or electrical activity is in the brain, or how quiet it is. And what we can see are a handful of areas of dysfunction. And so, in this person, we're actually seeing 5 different areas that are dysfunctioning, so to speak. And as soon as you get this kind of level of complexity, you try to introduce a medication, it's not going to have specific effects in all of those areas. So we have to bring into account the symptoms that somebody's having, how it relates to the specific areas we see. And then usually you're going to need multiple interventions to be able to get that brain to shift into a state where, quote unquote, normal, and no one really has a normal brain, but getting them to a point where they can leverage the areas of their brain so that they can function properly.
That is quite an interesting statement, though, to say that nobody really has a normal brain. Is that because all of us have suffered some kind of trauma that is going to manifest
I,
in some dysfunction?
there's a little bit of that, and then a little bit of the fact that we're all wired a little differently.
Hmm.
So, some people, we leverage different cognitive functions in order to interact with our world and regulate our internal states. And there's about 8 to 16 different cognitive functions. So some people leverage their brain in a certain way, and this is where, again, the medication one size fits all approach isn't effective, because in some cases people are leveraging areas of the brain in order to cope and regulate, and the medication removes that ability for them to do that, and so their risk of side effects goes a lot higher. So we look at that, and we utilize genetic testing, neurotransmitter testing, to really figure out, okay, what medications might be appropriate to stabilize this person while we work through and actually, get their brain to a point where it's rehabilitated, because the rehabilitation process takes a lot longer, right? I can introduce a medication in, I can get effects within a couple weeks, and I can get some stability. The rehabilitation might take 6 to 12 months, but we need stability in that system. People need to feel at least okay while they're moving through that rehabilitation.
So is that your goal, is to, you begin with addressing the problem immediately, but then you begin to heal the underlying condition, so you can either reduce the amount of medication a person is on, or get them off it altogether?
You got it.
Huh. So tell me the connection between mental health and physical health, because you hear that a lot, right? That stress is one of the biggest indicators of a potential future illness. And is there something that you can do or identify early as a bit of a precursor of, ooh, if you don't take care of that, you're going to have long-term problems? Is that one of the things that you can do?
Yeah. So this is a really, really great question. Mental versus physical stress. It's very difficult, again, without.
Do you want me to stop sharing this, or do you have another one you want to show
No,
us?
I actually had another image that I wanted to share here. The mental physical stress arguments. It's really difficult, because all that you see on the surface are symptoms, right? So you don't know. You might be, and I know this is what happens for me. Where my chain breaks, so to speak, is I will start developing cognitive issues, as well as anxiety and kind of emotional regulation problems, if I have too much quote unquote stress. But what does that mean? I mean, stress can come in all sorts of different forms. You see over here, I mean, these are just some potential sources of stress.
Can you read some of those out, just for those who can't see?
So you're looking at trauma, states of anxiety, worry, and fear, overwork, sleep issues, physical head injuries, traumatic brain injuries, inflammation, toxic exposures, infections, electromagnetic field stress, which is a big problem nowadays. Our regulations and restrictions on how much EMF exposure we can have just keep getting increased. Big issue, especially in the cities. Allergies, nutritional deficiencies, poor diets, maldigestion, microbiome distress. So imbalance of good and bad microbes in the gut, which, again, we aren't looking at through Alberta health testing. We look at 6 different microbes in stool tests. We're not looking at the full milieu of all of the different microbiome and bacteria and fungal species and viruses that run in our gut, that actually drive the immune system response and drive neurotransmitter production and so on and so forth. So there's a lot of different things that create stress. Now, when you get to the point where what I basically say, your stress tank is full, it's overflowing, what'll happen is you'll get cortisol changes, you'll get insulin sensitivity problems, you'll start getting immune regulation issues. And this is what leads to the clinical conditions and symptoms that, I could write 99% of the clinical conditions and symptoms are going to be related back to the stress tank being too full. Now, it might just feel like, oh, I'm stressed at work, I'm overwhelmed in my relationship, life is overwhelming, but life will feel that way because you are under-resourced, because your stress tank's overflowing. So sometimes it's not the stressors and the things that are going on around you. It's everything else filling your tank up, and you have no resources left to be able to manage any extra stress. So every little stressor throws you over the threshold to trigger this chronic stress response. So the physical, mental stress side of it, again, really interesting. And it's hard without looking at some sort of objective biomarker to say, this is actually what's going on. Like, I have a lot of people that come in and they're like, life is overwhelming. My work is overwhelming. I'm having issues in my relationship now. But it's because of other things going on, not allowing them to be able to regulate the everyday stressors that we have. So it's not always about, work stressful. Well, you should quit. You should get a new job. Okay, well, then what? Now I get a new job and I'm equally as overwhelmed. It's not the job. It's what's going on underneath that's not allowing you to cope with those everyday stressors. So
tell me the process.
There's a big entanglement there.
No kidding. Tell me the process that you would take somebody through when you do this baseline testing. You talk about biomarkers. You check out what their sort of their microbiome health is, what their brain response is. How do you move through treatment on that?
It totally depends on what's going on. So with the people that I see, they tend to be chronically ill. Most people have seen anywhere between 10 and 20 doctors of various disciplines before they see us. So, you're looking at your family doctors, sometimes a handful of specialists, chiropractic doctors, other naturopathic doctors, acupuncturists. They're kind of gone through the gamut of trying different things. So when they come to see us, they generally have between 3 to 5 major hits on their stress tank. So what we'll do is the way that I work is I always have a heart rate variability assessment, nervous system assessment, a cognitive potential test, which is basically a cognitive reflex, or we call it a cognoscopy, kind of like when you would get a colonoscopy. Because you can see if people are starting to have a delayed response in their cognition. And I think this needs to be standard of care as well in terms of preventing mild, moderate, and severe cognitive impairment, as well as dementia, because these are preventable conditions now. We know this with utmost certainty. And then I get a quantitative EEG, and in some cases I get a quantitative MRI as well. And then what I'm able to do with that information is I can see how well or not well somebody can regulate stress. I'm able to see if their cognition is suffering. I'm able to see if, what is affecting their brain and what areas of the brain are being affected. Is it an inflammatory problem? Is it a metabolic problem? Does it look like a nutritional deficiency problem? Does it look like an EMF exposure? Does it look like a hormonal imbalance? We have 20,000 brain maps with biomedical data to show these different patterns. Is quite incredible. And then I would utilize further testing from there based on their symptoms and their medical history. So if I knew somebody had been exposed to a water damaged building, I'm going to look into chronic inflammatory response syndrome, which post-COVID is the newest kid on the block for causing this. I'm also going to look if somebody has had a history of food poisoning, or they have chronic digestive complaints. Obviously, very first place I'm going to go is look at the gut, look at the microbiome. If there's a trauma response in the brain, which, by the way, probably one of the most underdiagnosed issues in our society is developmental trauma and difficulties managing dopamine. If there's an issue like that, then we get them plugged into either our neurofeedback program or get them referred out to a trauma specialist that can do specialized treatment in trauma and help them understand, where their traumas were and what got them here, what created some of the maladaptive responses that they might have. And so all of this you can kind of see through a brain map, and then you can create programs and that work to actually resolve the issue rather than just cover it up.
That's remarkable. So when you say that you've got 20,000 images of brain, so does it come up fairly easily? Are you able to sort of take a person's brain scan, run it across all of the different brain scans that are on file, and then be able to zero in pretty quickly on where
Yeah.
your problems are?
Yep. Yeah. And I've, for me, I can look at a map and I can zero it in pretty well. But we also have an AI algorithm that that helps us pick this apart as well, and helps us see blind spots that we sometimes have. So
I need you to just revisit what you said, is that we know that cognitive decline and dementia is preventable. That kind of
mm,
that shocked me as a statement, because I've never heard anyone say that. So when you say it's preventable, why do you say that? Because I think we sort of just accept that as we get older, we're all going to suffer cognitive decline. We'll probably have dementia if we live long enough. All of us are going to have Alzheimer's, but you say that's not necessarily the case.
it's yeah. So we all are going to, we're not going to function like we were when we were 20 or 30. So there is always a slow decline of cognition. The problem is when the decline becomes sharper, the slope becomes sharper. That's when we start struggling. So there's something called a P300 test, or what's considered a cognitive potential. We call it an event-related potential. It can start picking that up very early, because we know that people around the age of 30 to 50 are going to start reflecting an increased dramatic reduction in the P300 amplitude, and how quickly that reflex is happening. When a doctor, hits your reflex at your knee.
Yeah, your knee, and then your leg,
your patellar
leg
reflex.
flies up.
Yeah, so we can do that at the level of the brain, and we can see how quickly the brain is becoming consciously aware of what's going on. It takes an average of 300 to 400 milliseconds for us to consciously know what we're experiencing. Our brain knows it right away, but we don't consciously have access to it until 300 to 400 milliseconds after that. If that starts slowing down more, where it's going to the 500, the 600, and the amplitude's coming low, we know we need to start intervening. And it's actually, there's a great book called The End of Alzheimer's by Dr. Dale Bredesen. He was an Alzheimer's researcher for 35 years, and they've identified over 45 different issues that occur that will drive the accumulation of tau protein, build up of beta amyloid, build up of Lewy bodies, if you're showing Lewy body dementia. And it really is something that the drug-based approach has completely failed. Alzheimer's drug-based approaches do not work. So the only way around it is a program that can identify the areas that are pushing you in that direction, and then intervene, fix those underlying issues, rehabilitate the brain to a point where you go back into a neuroprotective rather than a neuroinflammatory zone. So he actually created a program that's really, really interesting. He brought it up for in front of the AMA, the American Medical Association, and they said, this is phenomenal, but I'm sorry, we're going to need a drug that we can give a dosage for. And he goes, well, we can't. We know that that's not going to be doable. There's too many different factors that a drug has to be able to influence. I mean, you're looking at the potential for needing to be on 40 different medications, and then we don't even know the downstream side effects of those. So they said, yeah, we're sorry, this is amazing, but nothing that we can implement. We don't have the resources to implement a training program across all practitioners so they understand how to do this, right? And he laughed, because he said, a handful of the doctors came up to him after and said, hey, I have referrals for you. I have a lot of people that I want to send to you, but we can't approve this program because it's not cookie cutter enough, essentially. So
what a shame. Okay, so I'm 50, so I'm at the upper end. So if you tested me, you'd already know whether or not I'm a candidate for early cognitive decline. Is it too late for me to take any measures now to reverse it?
Absolutely not. Absolutely not. Yeah, we've had some really interesting cases of moderate cognitive impairment, where they're basically, and this is the other interesting thing about dementia and Alzheimer's, is the gold standard is a mini mental state exam or a Montreal cognitive assessment, which is really just a questionnaire of like different cognitive exercises you do with people, it's very, very insensitive. So unless you're severely impaired, you're going to come up looking fine on that. So it doesn't catch anybody early. And that's the biggest trouble. We've worked with people that are in moderate impairment where they basically gotten the diagnosis of dementia, which Alberta Health is always really hesitant to give out because there's nothing we can do for people, right? So we don't really want to pull that hope from them. And, you know, to say, well, there's nothing we can do for you. Sorry about your luck. We've worked with people like that, and we've had pre and post MRIs showing that we've been able to actually improve the amount of gray matter, the volume of gray matter that is lost with these conditions. We've shown that we can improve that in individuals. So we know it's possible, even if you've gotten to that point. So there is a certain point where sometimes you can't regain function, but you can definitely stop the loss of it. So that's also important to know.
What an amazing area of research. Okay, talk to me about a few of the other services. We won't delve into them because obviously brain research is your expertise, but you had something like a cold laser, I think is what you told me on site. I've done hot laser treatment for a shoulder injury, and my gosh, it worked like a charm. I couldn't believe it. The first time I had a shoulder problem, I used a cortisone shot. Second time I used this laser treatment, and it's like it healed it. I haven't had any problems since. And so I'm kind of an enthusiast of trying to use those types of approaches, but I don't know what the cold laser is for.
Yeah, I'm definitely not the expert. Dr. Best in our clinic is the laser expert, but the really interesting thing about laser is it actually promotes the mitochondrial response in cells. So the generators, the powerhouse of the cell that actually drives and restabilizes inflammatory responses in the cell, and leads to healing. So it promotes growth factor expression, reduces inflammation, and actually allows for repair. Whereas cortisone, you're going to lower inflammation, but it doesn't promote repair. And actually long-term use of cortisone actually is damaging in a lot of cases. So it does the opposite of repair. It helps relieve symptoms, but the laser, prolotherapy techniques, perineural injections, phenomenal for repairing old injuries. And we've used it, cold laser on a lot of post-stroke as well. I've never seen anything better at stroke rehabilitation than that device. I'm just blown away every day that I see a stroke case come through. And we've had people that are 10 to 20 years post-stroke and they have no use of their hand. And you start doing it and putting them through a rehab program with the laser and they regain function. It's absolutely incredible how plastic the brain is. And I think if we're going to take anything away from today is that the idea, the scientific dogma that once you've gotten to a certain place, there's no turning back. I see that completely invalidated every day. That the brain is so incredible. Even in our 80s, we are still expressing stem cells in the medial temporal regions of the brain, which tells me that the brain can rebuild. It doesn't matter how old you are.
That's remarkable. Okay, so I do know that you treat cancer patients, because one of the conversations we had about some of the treatment that you do allows for cancer patients to maybe use less chemotherapy drug, which is great because I know chemotherapy drugs can have a really devastating impact on the body. I had one friend who told me that the chemotherapy actually was worse than having the cancer. And so just explain the connection there about how you're able to take on those kinds of cases.
Yeah, so I don't work with cases like that, but Dr. Best does. He's the specialist in the integrative oncology department. But what we'll do is we'll put people on programs that allow them, for one, to tolerate chemotherapies, immunotherapies, and radiation. We have a lot of great research on high-dose nutrient therapies for that. Working with the cancer microenvironment, so looking at what is driving the cancer behavior. So this is another dimension, when we're looking at like underlying causative factors of symptoms. When you're dealing with cancer, you also have to look at the individual behavior of the cancer. Because you could have 4 cases of breast cancer or breast carcinoma, and all of them will be behaving differently.
Hmm.
And so you can see this through onconomics, through transcriptomic testing of the cancer, and you can see where else we can intervene. We can utilize dendritic cell therapies, cancer vaccines, small oligonucleotide therapies. There's a new one called CoQR, which is another form of a cancer vaccine that actually basically teaches your natural killer T cells how to recognize the cancer so that your immune system can fight it. Fascinating therapies. So utilizing these types of approaches, and they're all individualized. They're all based on individual cancer behavior and individual immune behavior. So they'll be designed differently for each person. It's absolutely incredible in terms of the 5-year survival rate. Even of stage 4 cancers, it again constantly blows my mind. The survival rate and in some cases even the remission rate that happens if we're intervening early enough. So yeah, we're really wanting to work with the body. We don't, when we're doing, if the people are doing chemo or radiation, we don't want to intervene and push any therapies that are going to stop or hinder the effects of the chemo, but we know certain things that can be utilized at the same time as chemo that can help bring people's energy up so that they can tolerate the treatments. And that leads to much better survival rates as well. So,
I wish that I'd had a conversation like this at any point in my history with my doctor. Like, it feels like there's an entirely different philosophy that we're talking about here. And maybe it's underscored because we've acted for the last 2 years like the immune system doesn't exist because of a new virus that has entered into the picture. And I have so many people who contact me and say, why don't we ever talk about what we can do to keep ourselves healthy and to keep our immune system strong and be able to fight off new viruses or microbes? And that sounds to me to be one of the conversations that we need to have, whether you want to talk about it in the context of this current virus or some future mutation or some future new virus that's going to emerge on the scene. It strikes me there's got to be a better way to handle it than shut down society until we develop a vaccine and then have multiple doses of that vaccine because it's constantly mutating and we're trying to keep ahead of it. It just seems to me that there must be a better model or a different model. So how do you look at that issue?
Well, and I think this is the lesson that we need to learn on the medical side with SARS-CoV-2 is that if you look at a lot of the literature on exercise, metabolic capacity, low metabolic capacity has been the biggest predictor of severe cases of SARS-CoV-2 and death. So people with insulin resistance, diabetes, metabolic syndrome, obesity, cardiovascular disease, these encompass almost 95% of the death from COVID. And so I think that's the lesson that needs to be learned is how do we help people improve their first of all, measure their metabolic capacity, because that's not even done in a preventive setting in through any blood work or anything. And how do we teach them then how to improve it? Because that's the biggest factor. That has been by far the biggest issue. So I think that is a lesson that I hope that we can pull out of this is that, hey, we need to focus on promoting a healthier population of people and helping in some way creating maybe a reward system that rewards people for health choices, right?
Well, tell me a bit about metabolic disease and what that really means. Is that something that that is reversible? Is it because of lifestyle choices and diet and lack of exercise that we end up having impairment in our metabolic function? What is it natural? Is it genetic? What just tell us a little bit more about how you would diagnose this and what it really is, or how we can prevent it.
Yeah, I mean, metabolic issues are largely driven by problems with the mitochondria, which are they're basically an ancient bacteria that at one point invaded an animal cell and they started acting symbiotically. So the waste products from mitochondria are ATP, which are energy. That is the energy of the body. That is what our body needs to do every active cellular process. So detoxification, regulation of inflammation in the immune system, regulation of neurotransmitter and neuromodulation expression, healing, whether we heal, whether we repair, or whether we damage ourselves. So there are some genetic susceptibilities to metabolic issues, not as much as people think. It's very rare to have mitochondrial mutations. Really, the name of the game is to increase the number of mitochondria in your cells. The more of them you have, the better you can regulate metabolics and regulate all of the cellular processes and everything that our body does. And then giving our mitochondria what it needs to function properly, and removing what it doesn't need or what will block its activity so that it can function properly. So this is, again, complex question because there's a lot of things that will affect it. We talk about post-COVID syndrome. One issue, and you'll see, I'll just show you this brain map again. These areas that are lit up are all areas that are having metabolic problems due to chronic inflammatory response syndrome. And so there's a feature that 17 to 24% of the population have a genetic susceptibility to, where when we get exposed to certain agents that induce inflammation or certain biotoxins, so COVID is one of them, water damage building is another.
And the water damage building is because of mold? Is that what it is?
Mold, actinomyces family of bacteria, and endotoxins,
Okay.
which is gray and black water damage. If certain percent of the population gets exposed to those or gets a concussion, post-concussion syndrome is very common with this. What happens is an inflammatory response turns on, and the adaptive immune system doesn't have the ability to recognize what's driving inflammation up so that it can build antibodies, build memory cells, and bring the inflammatory system back to normal. So what will end up happening is mitochondria flip into what's called a cell danger response. And this was discovered by Dr. Navio in the late 90s, early 2000s. He deserves a Nobel Prize for this because this is driving probably 95% of chronic illness, including cancer. And then they won't bring glucose or fats into the mitochondria to burn energy. So what happens is your energy utilization drops to an 18th the rate at which it normally could function at. And this is a survival, evolutionarily preserved pathway that we think has been preserved because of exposure to virus and other pathogens. So if a virus gets into a cell, we don't want the virus to be able to hijack all of our cellular resources. So mitochondria can detect this and they go, oh, we're going to shut down all our resources. And then that virus won't be able to proliferate. It's brilliant, except for when the cell gets stuck in that state. This is going to lead to multi-system illness, so digestive problems, thyroid-related issues, hormone-related problems, brain-related problems, including cortical atrophy, which is the shrinking or loss of synaptic density in certain areas of the brain, as well as enlargement of certain areas of the brain due to what's called microscopic edema, which can only be seen with a quantitative MRI. You won't be able to see it. A human won't be able to see it with an MRI. You need a computer to analyze it. So all these systems start falling apart, and it's very difficult to obtain a diagnosis. And this is exactly what's happening with post-COVID. Brain fog, fatigue. Fatigue is number one symptom of a metabolic problem. Memory issues, focus problems, digestive issues, joint pain, muscle pain, cramping, headaches, migraines, vertigo or dizziness or disorientation, difficulties coping with stress, anxiety, and mood swings. And so these factors are not necessarily, oh, you're not exercising enough, you're not eating well enough. Sometimes it's a truly kind of a medical problem that needs intervention. But I think in a lot of cases there are, just healthy eating strategies, promotion of healthy foods, foods that aren't full of sugar. And, the biggest catastrophe is that the most unhealthy foods are the cheapest and easiest to access.
Oh, isn't that
Something about that needs to change. So there's a lot that can be done with education on how people can upregulate metabolics, light exposure, cold exposure in the winter, like these very important things that we've really gotten away from.
You mean we should be exposing ourselves to cold in the winter? I just hate the
Absolutely.
cold. Oh, jeepers.
Absolutely.
And cold showers in the morning too. I know that was one some people just swear by it. Is there something to that?
There is, mainly in winter, because we lose light exposure. The angle of the sun prevents us from activating a hormone called leptin, which actually is the opposite, basically the yin to melatonin. So melatonin goes high at night. Leptin is supposed to come high during the day, and that actually helps us regulate appetite, regulate hormones, neurotransmitters like dopamine. It regulates the immune system, and it helps us regulate fat metabolism through mitochondria. So again, a metabolic piece. So what happens in November, December? We get sad, sick, and tired. And this is because a lot of it is a lack of leptin, because we're not getting outside. And the antidote to not getting enough light or not getting outside, because again, sometimes you're at work, it's dark, you leave work, it's dark. The antidote to that is cold exposure. Nature gave us a solution. We just have gotten away from it. We're in warm buildings all day. We have remote car starters. We're in underground parking. We're not getting that exposure to help our leptin sensitivity. So this is why you'll see, like clockwork, every time this time of year. The busiest month of my year is November, because everybody's starting to get sad, sick, and tired.
Oh, you're giving me the worst advice, because I don't like that prescription, because I love having my hot showers. Okay, I'm gonna give it a try. But let me ask you, there's a few things that stem out of what you've just said, because one of the frustrations that some people have is, is there any way to test your body's metabolic health, so that you know whether you do have a natural immunity that will allow you to fight off a new virus? That's one of the discussions, is, can we get some recognition that not everybody needs a medical intervention for every new virus that gets developed? Is there some way that you can do a test to see whether or not you have a susceptibility, or you're likely to fight off something new?
Yeah, absolutely. Yeah, there's about 20 to 30 biomarkers that, in my opinion, need to be looked at to really know. VO2 maxes, which can be done at any exercise kinesiology or exercise physiology facilities, can look at that as well. Heart rate variability analyses that, I mean, a lot of the Apple Watches and stuff like that are looking at. I really like the Oura Ring, which I wear all the time. If you have a heart rate variability SDNN number of under 50, you're going to be severely metabolically impaired, and you need to make sure you make some shifts. If you're between 50 and 100, you're borderline, so you're okay, but it's recommended that you look into that. And if you're above 100 and 100 to 150, you're in really good shape. And this is measured in milliseconds. If you're above 150, you're in a dorsal vagal faint freeze overwhelmed state. And again, not necessarily metabolically impaired, but something that you need to take a look at in terms of being overwhelmed by stress easily.
And what is this test? SDNN?
SDNN. It's a standard deviation of the interval. So our heart rate is actually always speeding up and slowing down. So when we look at a heart rate, we kind of think, oh, I have a resting heart rate of 65. Your heart rate's actually speeding up a little bit above that and dropping a little bit below that all the time. So our heart's never steady state. If our heart was beating at a steady state, we're in trouble. If we don't have any heart rate variability, our risk of mortality goes up 5.3 to 8.2 times. So yeah, this is just honestly, a lot of these devices are measuring this now. And, sometimes not really telling you what to do with the data, but that SDNN number is incredibly important. 100 to 150 is optimal. Less than 50, big trouble. And you need to be doing something.
Okay. Were there more? That sounds like one I might need to book an appointment to get that test. But are there any others? When I ask this question about how do you figure out what your baseline is for your ability to fight off something new, are those the most important ones, or are there more?
Yeah, so other markers are like C-reactive protein, erythrocyte sedimentation rate, or ESR, these are blood tests, insulin and glucose regulation. Elevated insulin levels are a big problem. If people are fat, their fasting insulin's high, that's a big issue for metabolic problems. Leptin, which can't be done through Alberta Health, unfortunately. Thyroid function, complete blood cell complete blood cell count. So your white blood cells, your red blood cells, your hemoglobin, your iron, all those are your kind of your basic markers. And then there's some more complex markers, specialty markers like alpha MSH, which is a neuropeptide released by the brain, MMP9, TGF beta, which are immune markers. These all help us understand not only if you're at risk for a metabolic issue, if you're at risk for the innate immune system getting stuck on, which is what's happening with people with COVID. So the innate immune system is the immune system that is activated when we get exposed to an infection. So if you feel flu-like symptoms, it's not the virus that's causing that. It's the immune reaction to the virus that's driving that. It's the innate immune system. The innate immune system is easy to mobilize. It doesn't cost the body a lot of energy, which is why people with metabolic problems have trouble shutting that off, because the body's like, well, we don't have a lot of metabolic resources. This is the easiest way to keep us protected, is to drive the innate immune system up. Unfortunately, it's also what causes people to go septic. It's what causes pulmonary hypertension and the need to have to go onto a ventilator, and vice versa. So this is what's killing people.
All right. And it's also causing the long-term damage as well, because you'd mentioned long COVID. I know people who've had vaccine injury. Is there, can you test and address those issues as well?
Yeah, absolutely. Yeah. Yeah. And, and with vaccines and, there with any medical intervention, there's always risk. Sometimes the risk is very, very low. Sometimes it's a little higher. So the reality is that vaccines aren't going to be completely risk-free. And we know this, you look at the vaccine injury data, they're not. It's just, you need to kind of look at how has it shifted things for people? What has it done to the immune system? And then when we know exactly how it's manifested, we can go about intervening and kind of getting things fixed up. So
even if you have an injury because you've had COVID, because or for some other reason, it's not, this is going to be your life forever. You actually can start addressing those things. That's good to know too.
Yeah, and even severe, like the most severe cases we've seen of vaccine injury have been autoimmune demyelinating diseases. Those are fairly catastrophic, but you can still get repair. You may not get full repair. The likelihood is you're not going to get back to where you were, but you'll be able to get some good improvements, and you can get repair. It's just that you might not fix everything. That's just kind of the reality, but you can get improvements.
Fantastic. Do you have any more slides that you want to show us? Because I've got a few more questions I want to do for follow-up here.
That was it.
Oh, that's amazing. Okay, so let's talk then a bit about your the process. If somebody wanted, and I'll deal with it two ways, because we have probably a lot of medical practitioners who are seeing some of the deficiencies of the system that they're operating in, the way you've described it. And I know that you have an expansion plan, but give me some sense of what it is that what is the future of Nirvana? What do you see happening?
Well, our original goal was to have a Nirvana in every major city center in North America. So we've just actually expanded down. We'll be opening a clinic in Phoenix very soon. And yeah, I mean, we're looking to partner with anybody and everybody that is, feels really resonates with our philosophy and wants to see this expand, because, to me, this is how we fix old systems, is we build new systems that work better. And so that's kind of where we're at. Yeah, I mean, right now, the facility we have here in Mission in Calgary, we're fairly full, but we're always looking at opportunities to expand the philosophy. We have some training programs in place for practitioners as well that are interested in learning something different, learning how to look a little deeper.
Now, here's the real problem: is we've become so accustomed to thinking that government should pay for for this kind of treatment. Well, it's a test, so government should pay for it, and so it becomes a little bit difficult for people to figure out how to put this into their budget. And I don't even know if insurance covers it. But give me an idea of what the patient experience would be like. If you showed up saying you wanted to be a new patient, what would you put somebody through, and then we'll talk about how much it would cost.
Yeah, so it depends on what they're dealing with, right? You know, if it's a cancer issue, that's something that Dr. Best specializes in. If it's a mast cell activation syndrome issue, that's also his specialty. Dr. Smith, if there's a hormonal component or a digestive gastrointestinal component that people are struggling with, usually Dr. Smith is going to deal with that. If it's a musculoskeletal problem, that's Dr. Eric Nelson related issue. And then if it's a neurological, psychological, or immunological related issue, or a mystery illness that seems to be affecting many systems, that's something that I would work with. On my end, people come in, they get a brain assessment. It's about an 1.5 to 2 hour long process. And then they would fill out a bunch of questionnaires, would get all their lab record history, prescription history, everything like that. And then we would sit down and we'd go through their history, we'd go through their symptoms, their main complaints, and look at their brain maps and nervous system data to figure out, okay, you know, what do we think we're dealing with here? From there, and including the other practitioners, we would recommend further testing. Right? We're not going to know everything we need to know about, you know, what's going on, unless there's a traumatic brain injury and a trauma, a PTSD or developmental trauma or something like that. Then we'll know how to intervene right away. Otherwise, we would need to look at deeper testing. If we're seeing inflammation, we got to figure out, okay, what's causing that? So that's a highly variable component because it totally depends on the case. It's very case by case dependent. And then we would have them run blood work, urinalysis, saliva testing, stool testing in some cases. That's all done out of our facility here. If I need to see an MRI or an upper cervical assessment, I have them referred to a collaborative partner. We have Dr. Trevor Hillard, who's an upper cervical chiro specialist. He's able to get an MRI and everything like that. And then once we know what we're dealing with, we put a program together. So that may look like neurofeedback. It may look like trauma treatment. It may look like IV therapy. We may need some hormone replacement therapies. We may need some peptides. We may need some pharmaceuticals. And so we work with prescribing partners on that. And then, we just basically go to work on what do we need to fix here? How do we get rid of it? How do we get the body back into that state where it can heal again? And so sometimes that's a 6 to 12 month process. Sometimes it's a $5,000 process for more severe chronic issues, and cancer included if we're needing to do dendritic cell therapy, cancer vaccine, stuff like that. It may run as high as 40 to 50 grand.
Wow.
So it's quite variable. So we do have some financing companies that help people out if anything's needed like that. And we're always willing to work with people and meet them where their budget's at and just do what we can with the resources we have.
And how much is covered by insurance? Is any of it covered by insurance?
Insurance will cover follow-ups, consults, sometimes neurofeedback, and that's about it. Insurance will not cover testing. They don't see it as relevant to our practice. We shouldn't need to use testing in their eyes, which is a shame. But these are medical expenses, so they are tax deductible, which is nice. But other than that, that's about all we have to work with at this point.
Well, you've just persuaded me. I've been proposing the idea of health spending accounts, and now I'm feeling even more committed, because if you had government put a portion in and then they allowed you to get a tax deduction for a portion you'd put in, and maybe your employer puts it in, and then you're able to save it up over time, then it makes all kinds of interventions more affordable. If we don't start developing new mechanisms to help pay for this kind of preventative treatment, it's going to cost us in the long run. That's the real problem, right?
That's the thing. And you know what? It's the human condition. We wait until a problem happens, and then we decide that we got to do something different, right? And you're right. Like I think if we start sharing some of this data with insurance companies to show, hey, here's the money you're not spending on lifelong use of pharmaceuticals and surgeries that could have been prevented. And that's where what we need to do is we need to show the long-term savings. It really is an investment in all parties' interests, personally and at the institution level. I fully agree. I think if you had a health spending account system like that, things would be phenomenally different.
It would change the incentives, and it would create at least a pathway for entrepreneurs like you to be able to expand the practice, because we are so stuck in the old model, patients as well as doctors, as well as our health administrators. But I like what you said, that you just have to create something new and better as a parallel option, and then give people the means to be able to make the choice.
That's right. Exactly. Because it is a psychological thing too. You get used to something, and it's easy to overlook that there might be something else.
Well, it's amazing talking with you once again. Thank you so much for taking the time on this. And I'm delighted that I found you. I'll see if I can find the budget to squeak in there, or maybe get some tests and hitting that age where things can go really wrong really quickly. So as I talk to you, I'm thinking, oh my goodness, there's a lot there's a lot of complexity in the human body, and it's remarkable to me that we don't have this as some kind of baseline, so that you know what to look for, that you know the kind of things you need to be working on to be able to resolve issues. It almost should be the standard of care.
Yeah, it should, because preventative medicine is much easier and cheaper than rehabilitation medicine. So.
Isn't that the truth? All right, Corey Deacon, thanks so much for your time today.
Thanks a lot, Danielle.
You got it. And Corey Deacon is the medical director of Nirvana. As he mentioned, it is in Mission. They're getting to the upper limit of the kind of patients that they can take on. But if you're prepared to pay money out of pocket in investing in your own preventative health, in being able to try to resolve issues at root cause, I mean, it is a philosophical difference, right? Do you wait until you're sick and then medicate and address it afterwards, or do you try to take some approach to do the prevention up front? And what a shame that this is the way our system works, is that it rewards or compensates for sickness as opposed to reward and compensating for wellness. There you have it. So I hope you enjoyed that. We will be back at it again next week. I'm Danielle Smith, president of Alberta Enterprise Group.